Good afternoon, everyone. My name is Dr. Dorothy Fink, and I am the Deputy Assistant Secretary for Women's Health at the U.S. Department of Health and Human Services. Thank you all for joining us today for the 2024 National Women's Blood Pressure Awareness Week. It's to highlight the importance of blood pressure control and heart health for women, as well as share strategies to prevent and manage high blood pressure. About 60 million, or 44% of women in the U.S. are living with heart disease. Heart disease is the leading cause of death for women in the U.S. and disproportionately affects underserved and unrepresented communities, most notably non-Black women. But only half of U.S. women are aware of the risks of heart disease. And then when we think about heart disease, we also think about high blood pressure or hypertension, one of the major risk factors associated with heart disease. That affects almost 60 million women in the U.S. as well. And the reality is high blood pressure can impact women really across the lifespan. And so when you're at your doctor's appointment, we really encourage you to bring up your blood pressure, ask questions about it, talk about your family history, as well as ways to take care of your heart. So this week, during National Women's Blood Pressure Awareness Week, our theme is Empower Every Era, Blood Pressure Control Across the Lifespan. This theme emphasizes the importance of monitoring and controlling blood pressure across every stage of life and addressing the unique health challenges that women face from young adulthood to menopause and beyond. Heart health and high blood pressure prevention and control for women remains a top priority for the Office on Women's Health. Before we turn to our presenters, I wanted to share an exciting funding opportunity that focuses on hypertension control. The Office on Women's Health anticipates the availability of $10 million for the Pregnancy and Postpartum Hypertension Control Initiative, which is funding that aims to accelerate nationwide implementation of self-measured blood pressure during pregnancy and postpartum. Any private, either nonprofit or profit, or public entity located in a state is eligible to apply for an award under this opportunity in 2025. We will share a link to the forecast in the chat and hope that you will consider applying in 2025 to further this important work. And so thank you again for being with us today. I will turn it over to our moderator, Lieutenant Monica Geiger, to introduce our panelists.
Hello. Thank you so much, Dr. Fink, and welcome. My name is Lieutenant Commander Monica Geiger. I am the Regional Women's Health Analyst for Region 6 under the Office of the Assistant Secretary for Health at the U.S. Department of Health and Human Services. Howdy and a warm Southern welcome from our regional office in Dallas, Texas, where I have the pleasure of covering the great states of Arkansas, Louisiana, New Mexico, Oklahoma, Texas, and 68 federally recognized tribes. Many people don't realize that although HHS is a federal agency, we are also local. My amazing regional counterparts and I, located at 10 regional offices across the nation, are here to help you. I would encourage you to find and connect with your regional staff to get linked with the people who are doing this kind of work at the local, state, and regional levels. Thank you for joining us today for the important conversation of high blood pressure control and heart health for women. As a nurse and a certified CPR instructor, I have personally seen the long-term consequences of unmanaged hypertension, especially in women. I want to acknowledge that moving the needle on this issue is extremely hard. Long before I was a nurse, I was a young girl living in Puerto Rico, where we have some amazing food. And you won't see me giving up the food I grew up with anytime soon. There are, however, small changes that each one of us can make to improve our heart health, and we have some amazing resources today to help us do that. As Dr. Fink mentioned, heart health remains a priority for the Office on Women's Health as heart disease continues to be the #1 cause of death for women in the U.S. Many federal agencies continue to lead initiatives which support the heart health of women, including those created to address high blood pressure. Today, we will hear from 3 speakers across HHS who will highlight the latest resources available to support women in preventing, managing, and controlling their blood pressure in an effort to support better heart health for women. Before we dive in, we have a few housekeeping items. We encourage all attendees to use the Q&A feature at the bottom of your Zoom window to ask our panelists questions. We will hold all questions until the end. If you are having technical difficulties, please use the chat feature at the bottom of your window and a team member will reach out to you directly. Please note that anything you put in the chat and Q&A can be seen by others on this webinar. This webinar is being recorded and will be available for reviewing after the event on OWH's YouTube channel. All attendees will receive an email with the recording link once it's live. With that being said, let's meet our panelists. First, we have Neil Amari-Rish, who is the team lead for health education and research dissemination at the National Heart, Lung, and Blood Institute, part of the National Institutes of Health. She oversees health education and communication efforts spanning a range of heart, lung, blood, and sleep disorders, and manages the Heart Truth, Learn More, Breathe Better, and the Blood Diseases and Disorders Education Program and their respective partnership networks. She has worked as a public health educator at NIH for over 20 years and is passionate about translating scientific information into programs and resources that help people take better control of their health. Next, we have Dr. Janet S. Wright. Dr. Wright is the director of the Division for Heart Disease and Stroke Prevention at the Centers for Disease Control and Prevention. Prior to her appointment, she served as the acting director of science and policy within the Office of the Surgeon General, where she received the 2020 Surgeon General's Award for Exemplary Service. From 2011 to 2019, Dr. Wright served as executive director of Million Hearts, a national HHS initiative that CDC co-leads with CMS to prevent 1 million heart attacks and strokes over a 5-year period. Dr. Wright practiced cardiology for many years in Chico, California, and served on ACC's Board of Trustees, NCQA's Physician Program Committee, Center for Information Therapy. Lastly, but certainly not least, we have Mallory Polster. Mallory is a physical activity advisor at the Office of Disease Prevention and Health Promotion within the U.S. Department of Health and Human Services. In her current role, she leads the implementation of the National Youth Sports Strategy, supports the development of the Physical Activity Guidelines for Americans. Last year, she helped develop the Federal Hypertension Control Leadership Council's Physical Activity Action Plan. Prior to her current role, she has engaged with physical activity policy and promotion at both the national and local levels. Welcome, and thank you all for being here. So let's dive in. Our first speaker, Neil, will be highlighting the National Heart, Lung, and Blood Institute's new campaign called Yes You, aimed at addressing high blood pressure for women in early adulthood. The floor is yours.
Thanks so much, Monica, and thanks so much to the Office of Women's Health for inviting me to present today on that really important topic. Just for a little background, as Dr. Fink said, there are a lot of HHS agencies that are really interested in heart health, and that includes the National Heart, Lung, and Blood Institute. In 2002, we launched the Heart Truth to really raise awareness about women. At that time, only about 34% of women in the country knew that heart disease was the #1 killer. And so the Heart Truth program really served as a catalyst for movement on raising awareness about heart disease in women. And at that time, the primary audience was women 40 to 60, and particularly women of color. And when we launched the campaign, it introduced the red dress as the national symbol for women and heart disease, and it remains so today. So the Heart Truth has expanded. So we are definitely focusing on women. They're still a priority audience for us, but as we are well aware that it's still the leading cause of death for all Americans. So we are really looking at different audiences and how do we bring our scientific information, whether they're to the community health workers, to the healthcare professionals, or to populations that are disproportionately impacted by heart disease, and taking that information not just to know their risk for heart disease, but also to take action and to really protect their heart health. So I'll talk about our efforts that we're continuing for women. And as you see here, we're starting younger and earlier because when we make decisions now, younger in life, it really makes an impact long term. So next slide, please. So I'm going to talk about a new initiative under the Heart Truth and a little bit of background as to how we got here. So next. So as I had mentioned, when the Heart Truth first started in 2002, awareness was pretty low. Only around 34% of women knew that heart disease was a leading cause of death. And as time went by, we were really making good strides in awareness, and 65% of women by 2009 knew that heart disease was a leading cause of death. But 10 years later, we looked at that and that awareness had started to drop to about 44%. And three groups of women had the greatest declines in awareness. This was non-Hispanic Black women, Hispanic women, and then younger women ages 25 to 34. And then we also saw that fewer women were able to identify possible signs of heart attack over that time span. So as I mentioned, the development for this campaign started several years ago, but a lot of this background research really fed into the SU, which you'll hear more about. Next slide. So we know that about 1 in 16 women age 20 and older have coronary heart disease, which is the most common form, and that nearly 75% of women 20 to 39 have one or more modifiable risk factors. So that includes diabetes, high blood pressure, high cholesterol, they're currently smoking or have overweight or obesity. And of these, nearly half have two or more modifiable risk factors. And this is really higher in prevalence in African American, Hispanic, Latino women, both in terms of higher rates of risk factors and higher rates of heart disease. Next. So in terms of blood pressure, almost 20% of women in their 20s and 30s have high blood pressure. You'll see nearly 60% of Black women 20 and older have high blood pressure, and that's almost 40% of Hispanic Latino women. And it's really important for all women to pay attention to, particularly in those childbearing years, because high blood pressure really makes a difference in pregnancy too. And see, 1 in every 12 to 17 pregnancies in the United States, women are experiencing high blood pressure. So we really want to get the message out that it's never too early to start thinking about your blood pressure or your heart health. Next. So to do a little more research, we did formative research with African American, Hispanic, Latino women ages 25 to 39 to assess their knowledge, attitudes, and perceptions about heart disease, and also do some concept and message testing. And I'm going to share at a very high level some of the key findings that led to the development of the SU initiative. Next. So some of the questions we asked first, basic, how does someone know their heart is healthy? Healthy, normal, or good results were the most often cited, but healthy or normal were not always well known. So if you consider having low blood pressure to be a good sign of heart health, or others were not really sure what a normal or healthy range of blood pressure was. A few Hispanic Latino participants cited intuition or self-awareness as a way women can tell if something is wrong with their heart. So an example is a quote here. I think as women, especially, we're very in tune with our bodies, so we can tell if something's wrong or a little bit off. Next slide. So what is heart disease? The majority were familiar with the term heart disease, but less so among Spanish-speaking Hispanic Latino participants. And across the groups, there were similar definitions of what they thought heart disease was. Some cited high or low blood pressure, high cholesterol, having clogged arteries, having chest pain, having poor heart function, or perhaps poor blood flow or circulation. And there's also a lack of awareness about the term cardiovascular disease and how it was different from heart disease. Next. When we ask what causes heart disease, the most commonly cited were poor diet, lack of exercise, smoking, or having a genetic predisposition or family history. Less frequently cited was congenital issues, stress, having clogged arteries, or high blood pressure. But most agreed that being older, 50 years or older, increases risk. And there's also a sense of fatalism. So a lot of women thought that it can't be prevented or reversed, particularly if they had a family member who had heart disease. Next. So who gets heart disease? There's a lack of consensus on whether it's more prevalent in men or women. Some felt that men face greater risk because they don't take care of themselves and are less likely to see their doctor. Others felt that women were at greater risk because of the stress and focusing more on caring for others than themselves. And then a few recalled messaging that heart disease is the leading cause of death in women and that heart attacks or symptoms were different in women. Next. So when we asked, have you ever heard about heart disease from healthcare providers? The vast majority reported that their providers actually had not ever talked with them about heart disease. And providers discussed high blood pressure, cholesterol, their diet, but they didn't talk about it as a future risk factor for heart disease, so there wasn't that connection. And some of the women reported that during pregnancy, their OBGYN talked about blood pressure, but really just specifically about preeclampsia or salt intake or swelling and weight gain. So there wasn't really that connection again to the future risk of heart disease or stroke. And many women said they wish their providers had talked about heart disease, particularly those who had a family history. But others were also not so sure they wanted to have those conversations because they didn't want to really have that additional worry or stress, and they didn't really feel like that was something they needed to worry about since they were young. Next. So when we asked, is heart disease a serious issue for African American and Hispanic Latino women, they all agreed, and they frequently blame poor diet and popular foods in their cultures and lack of access to those types of foods. They also cited high levels of stress from working or caring from their families and neglecting their own care. And then reluctance to see a doctor was also frequently mentioned, particularly lack of access or cost, and then or cultural differences in making some women less likely to seek medical attention. Next. So we asked them, are there other health issues facing women that are more important? Compared to heart disease, cancer, particularly breast and ovarian, was considered more important than heart disease. And most attributed this to the attention that cancer gets over heart disease. And I thought it was really interesting here to hear some women say that, they thought cancer was more of a silent killer because high blood pressure is something we often think about as a silent killer. So it was really, that was interesting to me. And then also mental health and diabetes were frequently mentioned as issues as well. Next. So we asked them, are women your age talking about heart disease? Or if not, like, what are they talking about? So heart disease, not surprisingly, was rarely ever discussed among peers. They were talking more about stress and depression and reproductive health issues and more frequently discussed. African American women shared that diabetes was a popular topic among their peers, and the Hispanic Latina participants talked about COVID-19. So, and a few African American participants talked about being at risk at younger ages for heart disease, particularly because of growing rates of obesity. And so, though participants felt heart disease was a serious concern for women, again, I must stress many didn't consider it relevant for women under 40, but fortunately, they are open to having conversations about it, especially as they get older. Next. So when we were asking about their blood pressure, largely they agreed it's important to know their numbers, particularly if they have a family history of blood pressure. They felt getting it checked at least once a year would be easy, especially at a physical or at a kiosk at a pharmacy. Among Hispanic Latina participants, particularly, there was confusion over heart rate and blood pressure. So, some had mentioned they checked their blood pressure on their phone or watch it while working out and couldn't differentiate like the difference between what heart rate was versus blood pressure. And then none were really clear on what healthy blood pressure numbers are. And, some women had said that their providers never even told them what their numbers were when they got it checked. And so that's really an important issue. We want to make sure that people really understand what a healthy range is. Next. So when we asked women, how should we talk to you about heart disease? They really said that messages targeting young women should be uplifting and positive, thinking about their future. So if they're pregnant or planning, that having good heart health is really important for their pregnancy and having a healthy baby. Only a few women advocated for shock-based messaging to attract more attention to the issue. Many emphasize the importance of including detailed prevention and tips, so being specific about what to do and being actionable. There was mixed feedback on statistics. So some who one of them thought the statistics should be easy to understand, but really demonstrate the effectiveness of prevention rather than disease prevalence. So like what you see here, working out and healthy eating can drop your risk by X% for certain risk factors. And then they thought stories that were from their peers or perhaps celebrities were effective, particularly for women in their demographic. Next. And so all of this research really led to the development of our Yes You initiative. We know that women under age 40 consider themselves too young to think about heart disease, and they associate heart disease as something to think about as being older. And we really want to emphasize why it's important for you to think about heart health and take action that has both short and long-term benefits. So our messaging around Yes You is empowering. So yes, you can do something about heart disease, motivational and inspirational, like why you should care about heart health and know your risk factors. Actionable, so all of those things that we talk about, American Heart Association's Life Essential 8, promoting physical activity and knowing and controlling your numbers, knowing your family history, eating healthy, getting adequate sleep, and all of those things, making sure that people know what to do and why it's important. And then conversational and straightforward in tone, and then also giving a nod to cultural values. Next. So our messaging really focuses on the fact that we want women to first think about their heart health. It's never too early to understand your personal risk factors. That preventing heart disease and its risk factors can be done through small lifestyle changes. And we talk a lot about how heart care is self-care, and a lot of those tips that you can do in your everyday life that really can make a difference, and to setting good goals for yourself that are easily attainable. Learning about your own heart health and having those conversations with your provider. And then again, talking about it with your family and friends and others. Next. So we developed a wide variety of resources. I'll talk through these shortly. We have fact sheets that are available in English and Spanish, social media resources, a video PSA, which I'll put a link to in the chat shortly, a series of video testimonials, and then links to other information across NHLBI's website. But you can find all these resources here at this URL. Next. So as I had mentioned, our fact sheets, we have a series, one for a general audience of women in this age group, but then ones that are tailored specifically to Hispanic, Latino, and African American communities. And we'll continue to build out these resources. But I do want to acknowledge our partners at the Association of Black Cardiologists, the Links Incorporated Black Health, the National Alliance for Hispanic Health, and Lambda Theta Alpha Latina Sorority, who helped us assess these materials as well. Next. We have a variety of sample social media resources that people can download from our websites, along with social media posts that can be used. Next. And a new create your own graphic template, so women can share their story and talk about what tips that they are, or what tips they have for others and what they're doing to reduce their risk for heart disease. And as I had mentioned, we have a series of series of testimonials, and I'll share one shortly, and also a video PSA. But if you jump to the next slide, we'll hear from Sherwanda Knight, who talks a little bit about her story with preeclampsia.
My first child is my 8th pregnancy. During my pregnancy with her, I had developed preeclampsia towards the end, which caused me, after having her, I developed hypertension, which caused me to be on medication on a daily basis. During my 2nd pregnancy is when it got worse. I walked around with headaches. I seizured out multiple times. The blood pressure medication was not actually working. I ended up having my son at 33 and a half weeks. My mom, I think she was in her 30s when she found out she had high blood pressure. She never talked about preeclampsia or anything. She never discussed it because I don't think she knew anything about that. My grandmother, she died from an aneurysm and a heart attack. And she had high blood pressure. No one never expressed or explained that it could be hereditary or it's just something that happens just because of history. Preeclampsia, it has to do with your blood when you're doing your pregnancy. It causes you to have high blood pressure. It can cause you to go into seizures. It can actually turn into death if not treated. You do have to take some time for you, even if it's just, mental breaks, because if you don't have your mental status together, it can break down your body as well, which I learned in my journeys of life, making sure that I take a little time for me. So even if it's just an hour, taking a bubble bath, singing, and sometimes I do it with my children. We sing together, we dance together, making sure that we all are happy and, in our daily activities, little things that keep your stress level down. And I make sure that they understand it's important that I take my medication every day because of my blood pressure. Take a little time for yourself. You are important as well. Don't think that you're not important just because you're always doing something for your children. It's very important to include yourself and not to always put yourself in the background because you are someone. Yes, you.
So I'm thankful to Sherwanda and to the other women whose testimonies you'll see on our website when you visit for sharing their stories. And we're continuously looking for women who have stories to tell. So if you have patients, if you have women in your community, if you are a woman who wants to share your story, you can please reach out to me and we'll be happy to talk with you more about this. And I also, before I end, want to share a few other resources that we have available through the Heart Truth. We have a ton of materials for social media, for fact sheets, for however you want to distribute them, but tips for how to actually accurately measure your blood pressure. I think this is extremely important. There's information in the news this past week, which I was happy to see, about a study that showed how important it was to make sure your arm was supported while you were getting your blood pressure taken. And I think these little tips are things that we don't always know, and it's really important to stress that. We have fact sheets on pregnancy and your heart health, high blood pressure in women, questions to ask about your blood pressure, and so much more. So I invite you to visit our website, hearttruth.gov. At the end, you'll find that to download or order any of these materials. If you go to the next slide. And say, yes, you can help us promote heart health. Again, you can visit hearttruth.gov. You'll find all of the Yes You and all of our other educational materials. If you want to reach out, healthedu at nhlbi.nih.gov goes to our health education team, and we're happy to explore opportunities as we continue to build out the Yes You initiative for women of other cultures and ethnicities, and just women in general. Is a really important topic. So again, thank you to the Office of Women's Health for having me.
Thank you so much. And what a wonderful campaign. What a powerful message that we need to take care of ourselves, and that, yes, you can help us promote heart health. So thank you so much. And please put any questions that you have in the Q&A box, and we will address them at the end of the presentations. Before we turn it over to our next speaker, we wanted to highlight one of the resources created for this year's observance of National Women's Blood Pressure Awareness Week. The voices and experiences of women remain at the core of OWH's work. It is in this lived experience video you will hear from one of the women about her experience with high blood pressure during and after pregnancy, as well as her advice for other women who may have similar experiences. Here is Susan's story.
Hi, my name is Susan Boddicker, and this is my story with hypertension and pregnancy. I was an older first-time mom, so I was already going to get looked at. My pregnancy was basically unremarkable until the last month, and my blood pressure started going up and up and up to numbers I had never seen before, didn't know was possible. And I remember after the cesarean, I was laying in bed and looking at the monitor and seeing it 167 over something. And I thought, that can't be right. And I spoke to the doctor, and he said, we'd like to keep you here, send your son home and put you in CICU because we think you're going to have a stroke. No, I've got to go home. I have this new boy. I have a project due at the end of the month. I can't do this. I've got to go home. So they sent me home, and they said, well, just follow up with your obstetrician. And from that day to my stent, 32 years later, I had high blood pressure. I didn't know what it was doing to me. I didn't know the questions to ask. I had no idea that that was going to be a problem. I never paid attention to pregnant people until I was pregnant myself. So much of your mind is focused on the baby. And women don't think about themselves. And it starts early. We are the caretakers of the world. And we're putting other people first. We put our children first. We put our spouses first. We put our friends and our work first. But really, it's not just about your baby. It's about you. I just wish I had known that it was more of a problem than I thought, because then I would have asked the questions. I like to ask questions. I like to know things, but nobody said. And so I didn't know to ask. Ask for help, ask to be seen. and insist on being seen and have your questions answered. Really know your body and don't be afraid to speak up when things seem off. What is this? What's causing it? If you had high blood pressure before your pregnancy and you find yourself pregnant and you're at the doctor, you say, will this aggravate my hypertension? What can I expect to see? What can I do to prevent it from going haywire? Is there something I should avoid food-wise? Should I exercise more? Should I try to get a more flexible work schedule? Education, education, education. Be persistent in getting the information you need to treat yourself well during this really incredible time in your life.
Wow. Insist on being seen and get your questions answered. Such a powerful story and a great introduction into our next speaker's topic. Dr. Janet Wright will share the Centers for Disease Control and Prevention's newest resource, the Hypertension in Pregnancy Change Package. Over to you, Dr. Wright.
Thank you so much, Lieutenant Commander Geiger. Let me ask first if you can see my slide. Great. Well, good afternoon or good morning, perhaps for some of you. I'm so honored to be on this panel today with colleagues from NHLBI and the Office of the Disease Prevention and Health Promotion. I want to first thank the Office of Women's Health for their magnificent work to highlight the importance of heart health and the connection to hypertension. Fabulous team in OWH. I will be forever indebted. In addition to expressing that gratitude, which is deep and real, I want to say two things because I know I'm going to get wound up and I'm going to tell you a whole lot of stuff here in the next couple of minutes, but I don't want to forget to mention two things. Anytime I mention data, statistics about hypertension in the general population or in women, I want you to keep in mind that all of those data, all those numbers, those statistics come from a world in the United States at least, where we are still measuring blood pressure in a less optimal way than we should. We should be measuring blood pressure at home, self-monitored or self-measured blood pressure monitoring, home or out-of-office monitoring, and we will be able to make that available everywhere for everyone with high blood pressure or at risk of high blood pressure. And until we do, the numbers that we give are likely to be inaccurate. They're likely to be either overestimates or underestimates. So we want to move to a world where everyone with or at risk of high blood pressure has a monitor at home, a validated blood pressure monitor, and has a team with whom that person is in communion, managing or co-managing their blood pressure. Then the second thing I want to mention, several of my other colleagues have already said, when it comes to blood pressure measurement, technique is incredibly important. You can get lots of information about proper technique. We have some from CDC, but it's also from NHLBI and many other places. So when you take your blood pressure at home, please make sure that you're following those simple rules about the proper technique, and then you can rely on the readings that you're getting. So let me kick off here. I say I have no disclaimers or disclosures, but the fact is I'm absolutely rabid about the health we're going to generate, for the country when we, in a more timely way, detect and control hypertension in everyone. And this talk today is about in women and in hypertension in pregnancy. So warning, fair warning, I'm rabid about this topic. So this is what I want to cover today. I want to talk about what we mean when we talk about hypertension in pregnancy. There is confusion about the numbers, so let's clear that up. I want to talk about who gets it, who has hypertension in pregnancy, and why are we seeing so much of it? The third question is really important, is why do we care so much about hypertension in pregnancy? And then finally, what can we do? As again, a colleague mentioned today, it's so important to know what the risks are, but it's much more important to act on those risks because they are controllable. The risks are controllable. So let's talk about what is hypertension in pregnancy. These conditions all all qualify as hypertension in pregnancy. A person can go into a pregnancy with pre-existing or chronic hypertension. So maybe they've been hypertensive before the pregnancy, or they develop it early in the pregnancy. That's called chronic hypertension. If hypertension occurs after 20 weeks, it's called gestational, related to the pregnancy. Preeclampsia, again, as others have mentioned, is a form of hypertension in pregnancy that's associated with protein in the urine or some other signs of harm to the organs in the body. And it comes in two flavors, severe features or not severe features. Eclampsia is preeclampsia that has progressed to a stage where seizures are happening in that person. And then a person can have a kind of an amalgam of several of these, which is chronic hypertension with superimposed preeclampsia or eclampsia. Let's talk about the numbers, because there's also been confusion about this. Hypertension in pregnancy, hypertension in pregnancy is defined as a reading of more than 140 at the top number or more than a 90 on the bottom. Either one of those, two readings taken about 4 hours apart, would qualify as hypertension. Severe hypertension during pregnancy is much higher than that. So numbers of 160 and above on the top, or 110 or above on the bottom. And the reason these numbers are important, or these thresholds are so important, is that severe hypertension, documented two readings, usually within 15 minutes, if it remains that high, qualifies as an emergency, triggers the trip to the emergency room, or if in the hospital, triggers an alarm for those taking care of that person to immediately intervene. Chronic hypertension, or the numbers that you see of greater than 140/90, also merits attention, but it doesn't trigger that emergency level. So let's go here to something that is so important. I'm showing here the results of the CHAP trial. It's rare, frankly, in medicine that a randomized controlled trial can change practice or should immediately change practice, but this study, completed in 2022, was a game changer. Prior to this study, most obstetricians and gynecologists did not initiate medicine for treatment of hypertension during pregnancy until the blood pressure rose to that 160/1, at least over 100 level, maybe 105, for concern, very legitimate concerns that harm might be done to the baby, to the fetus. And studies had never been done to determine what was a safe level to begin treating hypertension during pregnancy. This is the study that cleared that question up for us. The researchers took two groups of pregnant people, pregnant with one fetus, and treated one group once the blood pressure got up to 140/90, and did not treat the other group until blood pressures of 160 over about 105 were seen. Bottom line, what came out of that study was evidence that treating blood pressure at 140/90 was actually better. For those women who had chronic hypertension, treating at 140/90 reduced the chance that that woman, or the women that were in that group, would develop preeclampsia with severe features, need to be delivered before term at less than 35 weeks. They less often experience placental abruption, a severe complication of pregnancy, or fetal or neonatal death. This was a game changer. And immediately the American College of OBGYNs and the Society for Maternal Fetal Medicine endorsed this study and began to recommend that women in pregnancy with chronic hypertension were treated medically as soon as they achieved blood pressures of around 140/90. So again, game changer and good news for preventing all manner of harm to both mom and baby. So we're going to move to who gets hypertension in pregnancy and why are we beginning to see so much of it. So first of all, there's a background in the United States of very high levels of blood pressure, of hypertension. 1 in 2 adults in the US has high blood pressure. 1 in 2 of us, 120 million people. Out of that number, 59 million of those people are women. And out of that 59 million, 1 out of 5 of women of reproductive age, roughly 18 years to 44 in the studies that have been done, 1 in 5 women has high blood pressure. So if we stop right there, we've got a large pool of women who have hypertension. Some of those women are of reproductive age, and some of those women will become pregnant and experience hypertension in pregnancy. If we look at the general population of women, only about 1 in 4 of women with high blood pressure actually has it safely controlled. So we've got a large pool of people with high blood pressure, again, some becoming pregnant. Over 43 million women then are at increased risk of the untreated, undetected, uncontrolled high blood pressure. That pressure causes heart attacks, strokes, heart failure, kidney failure. It's associated with cognitive decline or dementia and pregnancy complications. This is another way to look at it, and breaks it out somewhat by race and ethnicity. In the upper left corner, you see that the prevalence of high blood pressure among non-Hispanic Black women was almost 31%, double that of Hispanic women, and almost double that of white women or women of multiple races. I'll just, because of time, go to the bottom quadrant there, the lower left quadrant, that shows of women with hypertension who are on medicine, what is the control rate? And you see, again, quite a bit of difference by race and ethnicity among women with hypertension on medicine. Now, Hispanic Black women had a control rate of around 41%. They weren't even getting to 50% control. And of course, all of these data show that women of reproductive age with hypertension remain at risk for all of the complications that I've mentioned. Why do we care so much about hypertension? And it is because heart disease continues to be the leading cause of death in women, and hypertension is a major cause. As mentioned earlier, the awareness, thanks to beautiful work by NHLBI and others, awareness of heart disease risks among women rose, and it has fallen again. So it's time for us to start ringing that alarm. So why are we seeing such increased rates of high blood pressure during pregnancy? Here are a couple of slides that show one of the reasons why. On the slide, you will see an increase in the total percentage of hypertensive pregnancies, hypertensive disorders within pregnancy over a 10-year period. This is a 113% increase in hypertension in pregnancy. So let's look at the factors that go. Now, these are high risk factors for preeclampsia, and we're going to look over that same period of time. You see a slight increase in pre-gestational diabetes. That is a risk factor for preeclampsia. It's about a 57% increase over the decade. Another major risk factor for preeclampsia is having multiple fetuses, multiple, like twins or triplets. We've actually seen a decline in multiple births like that over this 10-year decade. But look at the rate of chronic hypertension over the same period of time. I think it's 125% increase in chronic hypertension over the decade. So no wonder we are beginning to see we have high rates of hypertension in pregnancy, and it continues to rise. So why do we care? This slide is a great depiction. It's actually from the Surgeon General's call to action back in 2020, showing all the organs in the body that are influenced by elevated pressure. You see in the lower left corner the pregnancy complications, but really every organ gets blood flow, and the elevated pressure in those arteries caused by hypertension affects each of these organs. I'll tell you, I also care about hypertension because we know what works to control hypertension. And seeing harm come to people when we have a preventable cause, this is the thing that keeps me up at night. This is another reason why we care so much about hypertension. The slide is packed with data, so let me just walk you through it. What you're looking at are those fabulous CDC maps. On this map, on the left, you see a picture of the country that shows death rates from high blood pressure in adults that are 35 to 64 years old. And the red indicates rising rates of death from hypertension at the county level. So this is over a 8-year period, 9-year period from 2010 to 2019. And basically, save a few blue areas in the country, almost every other part of the country, coast to coast and border to border, is seeing county level rises in death rates from hypertension in our parents. This age group, our parents, our caregivers, our workforce, and extremely scary. You see in the middle, it's broken out by race for Black adults, and you see rising rates more than blue. And then for white individuals over in that right picture, again, really a red map overall. So we care deeply about preventing and controlling hypertension. When we come to pregnancy, this slide shows on the left both short-term bad things, complications from hypertensive disorders of pregnancy in the mom, and in the lower figure, short-term bad things for the fetus. I won't read through them, but you can. And on the right side, the thing about hypertension pregnancy is that it marks both the mother and the fetus, or the child of that hypertensive pregnancy, for early onset and long-term elevated risk of heart disease and stroke, the other items that you see here on the slide. So for me, being able to intervene in hypertension in pregnancy is the opportunity for all of us to have a generational impact on health. So what can we do? Let's get to the action. I will say this is our set of goals in the Division for Heart Disease and Stroke Prevention. And I'll just say we are building out our work to improve timely detection and control of hypertension in women throughout the life course, including during and following pregnancy. And we, with others like the brilliant team at NHLBI, are helping to raise awareness of women's cardiovascular risk among women, but also among healthcare professionals. Million Hearts sits in this division. Million Hearts is a collaboration with CDC and CMS, and Million Hearts has developed a priority for postpartum and pregnant women with hypertension. The first output in that line of work for Million Hearts is the change package that was mentioned, and I just want to briefly walk you through that. It is a collection of strategies and interventions that have been shown to be highly effective in detecting hypertension, helping clinical outpatient teams detect high blood pressure during and following pregnancy, to make sure safe medications are used, advance the practice of self-measured blood pressure monitoring, using aspirin to prevent preeclampsia, making transitions in care effective and safe, and also providing counseling to help women reduce their cardiovascular risk over time. This was created with 7 clinical partners, and there are over 350 tools and resources that can be adopted and adapted. I'm not going to go through this in detail, but I want to show you both the interventions and the strategies that are included in the change package. And this is the format for all of the change package produced by the Million Hearts team. These are change concepts and change ideas. And these are customizable by outpatient clinicians who want to improve their performance and their care around hypertension in pregnancy. A sample change concept is helping staff interpret blood pressure medicines and diagnose hypertension in pregnancy. These are 2 change ideas from the package. If you chose the one on the right, you can find all of these tools that have been garnered and gathered from across the country. They've already been in use, so they've been road tested and they're ready for adoption. We have a chart showing the antihypertensive medicines that are safe in pregnancy. We know which ones are not. It's handy to have this, and clinicians can actually use this chart to program their electronic health records to create flags and make sure these drugs are on the protocol for pregnant people. We have lists about medications that are safe in lactation. This is a right out of the change package that shows that women who are at risk for preeclampsia including those with chronic hypertension, need to be on aspirin. We know that many who qualify for aspirin are not being prescribed it, or maybe they're not understanding why they should take it. This study actually showed that when aspirin is used, low-dose aspirin compared to no aspirin, $350 million in cost savings if this guideline was fully implemented. It's also supported by ACOG, by Society for Maternal Fetal Medicine, and the USPSTF. Self-measured blood pressure monitoring, you'll see if you access these slides, links to more information about SMBP, which has been shown in multiple domestic and international guidelines as the most accurate way to diagnose and to monitor high blood pressure. Nice infographic from the change package showing those tips about proper technique. And that applies to whether you're measuring blood pressure at home or in an office. I'll just going to move by this. I want to make sure I feature the Hear Her campaign, a product of one of our sister divisions at CDC, urging individuals, both pregnant people, the people who love them, and the clinical teams who care for them, to listen when a woman notices something is wrong and to make sure that she is connected to care if that should happen. More resources there, including in English and in Spanish. So I do have some things that you can do, which is help us to get the change package out into the world. We're happy to provide some technical assistance if you need any with it, and happy to, if you find tools and resources, we would love to incorporate them in the next version. Please join us in the next Hypertension Pregnancy Action Forum. There's a QR code here to register, or please feel free to contact me if you need more information about that forum. You're all welcome. And then I'm not going to go through these resources except quickly. We do have information about women and heart disease accessible at the link below. Live to the Beat is a campaign out of Million Hearts, really looking designed by African Americans for African Americans to improve health habits and reduce their risk of heart disease and stroke. We have a number of toolkits, other change packages, information, new information just recently released about heart valve disease in the United States, which tends to be diagnosed later in people of color and also in women. Best practices guide and clearinghouse. Change package in cardiac rehab, which follows that same pattern. Fewer women participate, fewer people of color are referred and are able to participate. And then finally, I'll close by just saying this is the case for hypertension. It's common, control is not. It's harmful, we're losing ground. It is inequitable, it's costly in terms of lives lost and harmed, as well as dollars spent. And we know what works, and it's time to make that what happens. This is our chance for that generational impact. And I'll close by saying, this country has made healthy things the norm. We don't litter and we hold each other accountable. Friends don't let friends drive drunk. Non-smoking, it's a norm. Seatbelts are a norm. And it's time to make hypertension control in pregnancy the norm. Thank you so much. And I will turn it back over to Lieutenant Commander Geiger.
Thank you so much. What a wonderful presentation. And I just want to plug really quick the importance of the Hear Her campaign. That's such an amazing initiative. It was so amazing that the Texas Department of State Health Services actually decided to work with Hear Her and co-brand it. And so now we also have Hear Her Texas. So for those of you who are in Texas, you can also check out the Hear Her Texas campaign. And so states are adopting this as well, which is amazing. So thank you so much, Dr. Wright. Please put any questions that you have in the Q&A box again. And then lastly, we have Mallory from the Office of Disease Prevention and Health Promotion, who will be sharing the mid-course report from the physical activity guidelines, focusing on implementation strategies for older adults. Over to you, Mallory. Thank you.
Thank you. And thank you to OWH for having us on this panel. I think I'm going to take us full circle here as Niall started with the message that it's never too early to focus on your heart health. And I'm going to bring us to the other end of the spectrum, that it's never too late. And I'm also really excited to dive deeper into the topic of physical activity. So older adults do have the highest rates of hypertension of any age group. These data here come from the Healthy People 2030 objective to reduce the proportion of adults with high blood pressure. And as you can see here, 76.9% of adults age 65 years and older have hypertension. So this is a very important population for us to focus on, and physical activity plays a key role when it comes to promoting heart health. Physical activity can both independently reduce the risk of cardiovascular disease and can impact other factors that can affect cardiovascular disease, such as body weight, blood pressure, cholesterol, and type 2 diabetes. The first column on this slide highlights immediate benefits that can occur with a single bout of physical activity, such as reduced blood pressure and improved insulin sensitivity. Physical activity can also reduce the risk of heart disease, stroke, hypertension, adverse lipid profile, and type 2 diabetes. There are several long-term weight-related outcomes. And lastly, physical activity can help slow disease progression of hypertension and type 2 diabetes. So whether you're trying to prevent disease from occurring, prevent the progression, or reduce symptoms if you already have cardiovascular disease, we know that physical activity has a positive impact at every point along the spectrum. So you can see how reducing blood pressure through physical activity can be an example of primary prevention and reducing that risk for developing hypertension in the first place. For many older adults, secondary or tertiary prevention will be more relevant, but physical activity has benefits for people who already have hypertension, including a lower risk of increased blood pressure over time, reduced cardiovascular disease progression, and lower risk of death from cardiovascular disease. In addition to the benefits related to hypertension prevention and control, I would be remiss not to mention the many other benefits that physical activity has for healthy aging. Some of the benefits that are especially relevant for older adults include those related to brain health, such as improved cognitive function, reduced risk of dementia, including Alzheimer's disease, reduced anxiety and depression risk, and improved sleep. There are also benefits related to improved physical function. Physical activity can help older adults perform activities of daily living more easily, so they can complete those everyday tasks like getting dressed, cleaning, or grocery shopping, and really maintain independence as we age. Physical activity has also been shown to prevent or slow the progression of many chronic conditions that are common among older adults. Of course, those related to heart health that we've already discussed, as well as others such as osteoarthritis and certain types of cancer. And lastly, there are important benefits related to fall prevention. Older adults are at higher risk for fall and fall-related injuries, but physically active older adults are less likely to fall than their sedentary counterparts, and if they do fall, less likely to be seriously injured. And even some of these benefits can relate back to hypertension, thinking of those mental health benefits I mentioned, like reducing stress and anxiety and improving sleep. So how much physical activity do people need to achieve these benefits? Well, that's where the physical activity guidelines comes in. The first edition of the physical activity guidelines was released in 2008 as the first comprehensive guidance on physical activity from the federal government. 5 years after the release of the first edition, HHS released the first physical activity guidelines mid-course report, focusing on how to get youth more active to meet the guidelines of at least 60 minutes a day. In 2018, 5 years after the mid-course report and 10 years after the first edition, HHS released the second edition of the guidelines, reflecting an expanded evidence base. So the main difference between the full editions of the guidelines and the mid-course reports is that the full editions are examining health outcomes, while the mid-course report are examining the outcome of physical activity. So what strategies work to get people to move more? So the latest report was released last summer in 2023, and that was another mid-course report, this time focused on how to get older adults more active to meet the guidelines. And of course, we are already looking ahead to the next edition of the guidelines. So this graphic here depicts the key guidelines for older adults. First, older adults have the same guidelines as all adults to get at least 150 minutes of moderate intensity aerobic physical activity each week and at least 2 days of muscle strengthening physical activity each week. In addition to that, older adults should get multi-component physical activity that includes aerobic, muscle strengthening, and balance activity. So getting that mix of activity types. And when older adults can't meet these recommendations because of chronic conditions, they should be as physically active as their abilities and conditions allow. Not only do older adults have the highest rates of hypertension, but they have the lowest rates of meeting the guidelines. Less than 15% of adults age 65 and older in the United States meet the aerobic and muscle strengthening guidelines. This graphic depicts data from 1998 to 2018, and although older adults have become more active over the past 2 decades, they're still continuing to become less active as they age. Additionally, there are disparities in physical activity levels across different demographic groups, and especially during National Women's Blood Pressure Awareness Week, it's important to note that women have lower levels of physical activity than men. So we really need to consider older women in our efforts to increase physical activity levels. There are many barriers to getting or staying active that can contribute to these disparities, and that can include individual level barriers like chronic health conditions, fear of falling, or physical or cognitive limitations, even pain, as well as more community level barriers like inequitable access to spaces and equipment, or even neighborhood environment characteristics like low quality sidewalks or poor lighting. So when developing the mid-course report, HHS sought to identify strategies that can help reduce these barriers and make it easier for all older adults to get active. The mid-course report highlights strategies for a range of audiences. Hopefully you all will see yourselves in some of these, for policymakers, exercise and health professionals, clinicians, gerontologists, built environment professionals, local, state, territorial, and tribal leaders, and others working with older adults. The report highlights evidence-based strategies and interventions to support physical activity among older adults in a variety of settings so that they can achieve the benefits of physical activity. It also reinforces that there are many benefits of physical activity, especially for healthy aging, and that it's never too late to start or restart being active. So let's dive into the key findings here. While physical activity programs and interventions can occur in many locations, such as places of worship or work sites, the systematic literature review that informed the mid-course report identified the community, healthcare, and home as key settings where physical activity interventions have been implemented successfully. It also identified policy systems and environmental approaches, behavior change, and physical activity programs as effective strategies. So the first of the key settings is the community. The community setting can be defined as the places and environments where people in a particular geographic area live or congregate, and this can include places like schools, gyms, senior centers, as well as the environment like sidewalks, parks, or trails. Next is the healthcare setting like doctor's offices, rehabilitation or physical therapy clinics, and nursing homes. In the healthcare setting, older adults can receive that tailored care and specific guidance based on their individual situation or chronic condition. And older adults with hypertension or other cardiometabolic diseases will likely interact with the healthcare setting, so this is a really key intervention point, and can also offer that professional oversight that really can provide the extra assurance to individuals who are maybe just getting started with physical activity, or maybe they have concerns about getting active with a chronic disease. Maybe they have questions about medications they're on. So providing that medical oversight can really help people feel confident and safe in being physically active. And the last setting is home. Many older adults spend much of their time at home for a variety of reasons. This setting really removes some of the barriers to being physically active because being active at home is something that can happen no matter the season, weather, or time of day, and doesn't require any travel or transportation. The home setting also provides opportunities to engage family members or to add physical activity to daily routines, such as gardening or doing household chores. And the home setting is also an important part of maintenance of health behaviors. So, for example, if someone has just left a cardiac rehab facility, they're going to need to maintain their health once they leave and go back home so that they can prevent and reduce the risk of future complications. So now moving on to the key strategies. Policy systems and environmental strategies are population level strategies, such as those related to transportation and neighborhood environments. And one strategy that's been shown to increase physical activity among older adults is making communities more walkable through community design. Walkable neighborhoods provide easy access to a mix of destinations like affordable home types, cultural centers, food outlets, parks, and trails. And they have connected networks of activity-friendly routes, such as safe and accessible sidewalks, safe curbs and intersections, multi-use trails, and convenient public transit. So communities like these give those at risk of hypertension and other chronic diseases greater access to physical activity opportunities. Next, we have behavior change strategies like cognitive behavioral strategies and physical activity counseling. These are individual level approaches to influence knowledge, skills, attitudes, and beliefs. So for example, this might be helping someone understand the benefits of physical activity for hypertension, prevention, and control, or maybe helping someone with limited mobility find activities to get started with, like chair exercises, or maybe helping someone set and work towards goals. Maybe it's walking to the mailbox and back, and then the next week it's walking to the mailbox at the next house and back. So helping people set goals and increase their physical activity over time. And behavior change approaches are often components of physical activity programs and interventions and can help people build that self-efficacy to change their physical activity behavior. And these strategies can also be incorporated into broader hypertension control interventions that just include physical activity components. It doesn't have to be an intervention that's specifically designed to increase physical activity alone. And the last strategy here is physical activity programs. Physical activity programs vary widely in the intervention design and the strategies used. There are structured exercise programs that guide participants through specific exercises or prescribe a specific set of exercises, as well as lifestyle-based physical activity programs that encourage participants to engage in more physical activity throughout the day, typically beyond or in addition to structured exercise. And both structured exercise and lifestyle-based physical activity programs can help people find new ways to be active that kind of fit in with their lifestyle. So healthcare providers can help connect patients at risk of or with hypertension to physical activity programs in their community that can help them get active on a more regular basis. Throughout the mid-course report, which I'll include links to and a QR code at the end, you'll find 6 real-world examples that put a spotlight on how different sectors, programs, and communities are implementing the strategies described in the report. So you can read about how the city of Portland prioritizes age-friendly infrastructure, how Detroit Parks and Recreation offers resources and services to help community members get active and build connections, how Enhanced Fitness helps older adults get more active and reduce the risk of falls, how the Newington Senior and Disabled Center provides a welcoming place for older adults and people with disabilities to get active, how the University of California, San Francisco Cardiac Rehab helps people with heart disease, and how Walk with a Doc combines movement and conversation to help people of all ages take steps towards a healthier lifestyle. So I encourage you to read the examples that relate to your work and explore these in the mid-course report. From one-on-one setting to the policy level, everyone really has a role to play when it comes to increasing physical activity among older adults. If you do work with older adults one-on-one, maybe you're an exercise professional or a gerontologist, you can really help create those trusting relationships, provide that direct guidance, and implement some of those individual level behavior change strategies, or maybe even lead a physical activity program. If you're at the organizational level, like a community center, a cardiac rehab facility, or a faith-based institution, you can create and manage physical activity programs and provide spaces and facilities for physical activity and social interaction for the older adults that you serve. And if you're at the community level, maybe civic associations, housing authorities, or transportation, you can create those activity-friendly and age-friendly environments through community design. And then finally, policymakers and decision makers like local and state government officials, tribal leaders, and health system administrators can really set those policies that help facilitate physical activity. Alongside the release of the mid-course report, we also released some new Move Your Way materials to help people promote physical activity among older adults. Move Your Way is the promotional campaign for the physical activity guidelines. All campaign resources are free to use and available in English and Spanish, and they're user tested to ensure the messages are motivating to the audience they're trying to reach. The QR code on this side will take you to an introductory video where you can learn more about the campaign, but I'll also include that in the chat later. But instead of telling you what it is, I will just show you an example here. So as you could see, the campaign really tries to change the conversation about physical activity to help people understand that lots of things count as physical activity. Even small amounts of movement can add up, and people can find ways to be active that work in their lifestyle. There are several Move Your Way resources that are specifically designed for older adults. Fact sheets, posters, and videos like the one you just saw that explain why physical activity is key for healthy aging, what kinds of activity older adults need, and offer tips to overcome common barriers. There's also a fact sheet for healthcare providers who work with older adults on how they can talk to older patients about getting active. The Move Your Way materials point people to the Move Your Way website, where people can learn more about the benefits of physical activity, find tips to get moving, and create a personalized physical activity plan using an interactive tool. And I will actually pull that up for us so we can kind of walk through and make a plan together. So we are on the Move Your Way website here, and I'm going to click down to the older adults section, and I am ready to make a plan. So I am going to make my activity plan, and it's asking me why I want to get active. So I might select age well, have better balance, and ease pain. And then I'm going to hit continue. It's asking me if I want specific types of activities. I'm kind of open to all activities, so I'm just going to continue here. And then I'm going to scroll through and add activities to my plan. So let's see, dancing. I would love to go to a salsa class this week. That'll be 30 minutes. And gardening, I'll probably garden for about 40 minutes this week. I've got some weeds to pull up. And let's see, household chores, definitely some household chores, 10 minutes, probably at least 3 times. And then let's see, I definitely go for walks, so let's look for walking. I'm going for walks most days at least 10 minutes. And so I'm seeing here that I've met the aerobic goal, not quite the muscle strengthening yet. So I'm actually going to scroll up and click to just look at those muscle strengthening exercises to see if anything, if there's another activity I can pick. Ooh, I see resistance exercises, and I do have some that I'm supposed to do prescribed by my physical therapist, and I'll add those twice this week. So now I'm going to review my plan here. I've got tips and resources related to the motivations that I picked. And then I can actually create and print the tracker so that I can look at these goals that I set this week and actually fill this out and track over time if I met my goals. So that is just an example there of the planner. And you all can take that for a test drive yourself if you'd like at health.gov/moveyourway. So I really encourage you all to use these free resources. The QR code on the left side of the screen will take you to the community resources page where you can learn more about the campaign. And the QR code on the right will just take you to the campaign materials. So you can find all the materials for different audiences like older adults or healthcare providers. And if you're managing heart healthy programming for any age group, these can be great materials to use to promote physical activity in your work. And then lastly, in addition to using those Move Your Way materials, encourage you to download and read the mid-course report and sign up for email updates to stay up to date on the physical activity guidelines, the Move Your Way campaign, and other physical activity content. So with that, I will say thank you. I'll add all these links to the chat as well and look forward to continuing this conversation.
So thank you so much, everyone. Thank you for highlighting such amazing resources supporting women's heart health. And we're going to transition into our Q&A section now. And I'd like to mention that Mallory has been an amazing resource for my region and for us personally in taking these federal resources and bringing them to the regional and local level. So I would really encourage everyone to engage Mallory and engage your regional staff to talk more about these initiatives and also how we can bring them to the local level. So thank you everyone to the panelists for your resources. We had some great questions come into the chat. And so the first thing that I noticed is that there's a lot of questions about how to select a blood pressure cuff and what kinds of blood pressure cuffs that people should be using. So Dr. Wright, I was wondering if you could help us out in talking about what kind of cuffs are more accurate. Should we be using a wrist cuff? Should we be using a bicep cuff? I know I'm confused. There's so many choices out there. So how do we know what to choose when it comes to self blood pressure monitoring?
Thank you so much, Lieutenant Commander, and all of those of you who've asked questions about this, because it's a very important question and important knowledge to have. It's critical that you use a cuff that is the right size for your arm. We've learned, looked at this pretty closely, and we found that even the definitions of what's large, extra large, small, medium, it varies from manufacturers to manufacturer. There's no standard terminology there. So it's very important for you to get a cuff that fits your arm, is not too tight and not large, because that can alter the pressure reading. Secondly, you want to get a monitor, a blood pressure monitor that comes off the validatebp.org list. All the monitors that are listed on that resource have been tested for accuracy. There are cuffs that have been tested during pregnancy, and those are indicated by a little asterisk within that validatebp.org list. We're working, as many others are, to get more manufacturers to go through the validation process, and including during pregnancy, and to get those posted on validatebp.org.
Great information. Thank you. And do you know, are these BP monitors covered by insurance? Is there some help for folks who might not be able to afford?
Yes, great question. Over 40 states in the state Medicaid programs cover the validated cuffs in some respect. Some cuffs, some Medicaid programs cover more. They provide more money for coverage, and some less. So it varies. I do have a link to an analysis that we did back in February. I'll put that in the chart so people can, or in the chat, so people can look up their state. Many commercial payers also cover cuffs. The cuffs are not yet covered in Medicare. And so we are all working with our colleagues in CMS to hopefully eventually get those covered as durable medical equipment.
Thank you so much for that. And then we had a question come through about what happens when the doctor or nurse or medical assistant is not taking your blood pressure accurately. How can we be our own best patient advocates when it comes to blood pressure monitoring? And I think one answer that I would advocate for is check your blood pressure at home. Um, Checking your own blood pressure. I know, Dr. Wright, you mentioned that we should all be checking our blood pressure at home, and that's really the best way to do it.
You're right. And Lieutenant Commander, you gave me another answer. I put an answer in the chat, which is, what I sometimes say is, wow, that's, I heard somewhere that I'm supposed to have both feet on the floor, or I hear I'm not supposed to talk, right? I'm not supposed to talk because people are talking to you while you're getting your blood pressure checked. So I just kind of cue them to, that your reading is not accurate. The other thing that just fries me is that people they'll take your blood pressure and not tell you what it is. It's not a secret, a nuclear code or something. You should know when someone checks your blood pressure, what's the reading? And then if they don't say, and therefore you should, you've got to ask, should I do anything about that? Is that normal? What should I do? But your suggestion, Monica, was that you can also say, hey, that's not like my reading at home. And that's another cue for them to perhaps take it a second time and to make sure they're using that pristine technique. It is hard in a busy office to find that quiet space, to take the time to have a rest for 5 minutes, but it's absolutely crucial. Otherwise, you can't depend on the numbers, and then you can't get to the recommendation.
Exactly. And white coat syndrome is real.
Absolutely. Absolutely. And we want to avoid over-treatment and under-treatment, and also assigning a diagnosis to someone when it's not true. So monitoring at home is your best way to know, do I have this or not? And what should I do about it?
I think just to add to that too, and in my own experiences, I often will ask or tell people to ask to have your blood pressure taken at the end of your appointment too, when you're not so anxious. And then, so feel empowered to ask that. And I think, again, like you're saying, Dr. Wright, know kind of what the accurate steps are. Don't eat or drink anything before. Make sure your feet are flat on the floor. Make sure you feel relaxed. I think those are all really important things to know going in, and not to be afraid to ask. And if you visit our website, hearttruth.gov, we have a lot of resources that have those tips there. So you have them, you have questions to ask your provider. We have trackers so you can write that down. So I think going to your appointments and having those also help you. So then make sure you get your numbers and then you can ask the appropriate questions. Because you're absolutely right. There's been so many times in my own experience that they will take it, don't tell you your blood pressure, and walk out the room. And I'm like, hey. So I think it's important to be an empowered patient.
Absolutely. Great answers. Thank you so much. And so the next question was asking, what are efforts that currently exist for immigrants? Especially as it is commonly seen that immigrant health worsens more over time. They're in the U.S. as opposed to being in their native country. Region here where I sit in Region 6, we cover about 2/3 of the U.S.-Mexico border. So this is really something that's on top of mind for my office in particular as well. And I know there are some specific population-based resources that all three of you guys have. So if you'd like to speak a little bit to that.
Well, I can say that I did reference the Hear Her campaign, which is available in Spanish and English. We don't yet have change packages in multiple languages, but we hope at some time to produce that. I will say that sometimes individuals new in the country don't have medical care and seek care in federally qualified health centers. We have they're just doing a fabulous job in blood pressure control in FQHCs throughout the country. It's been a pleasure of ours to work with them. And so definitely look to HRSA and NAC and the FQHCs as a good source of care.
Yeah, and I will add, of course, all Move Your Way materials also available in English and Spanish, but they're also customizable. We recognize that there's not going to be a one-size-fits-all campaign that we can share out. And so we really look to community leaders to take what we have and make it fit for the specific populations that they are trying to reach. And that might be swapping out a picture for a different photo that's more relevant to their community. Or it might be creating new materials. And we love to work with communities on that. So if whoever asked the question, if you're interested in maybe designing materials, I'll put the contact us link in the chat to work with ODPHP to customize campaign materials and help tailor it to your community. And I'll also put the link to the CDC State and Health Media Center. All Move Your Way materials are available on there as well. So you can use that resource just to swap photos and add your logo, which I know is of interest to a lot of groups as well.
And just I'll add to that, definitely the federally qualified health centers. And I think the importance of working with organizations that reach those communities. And we do a lot with community health workers. So I think empowering those organizations and equipping those organizations with information that they can tailor to meet the needs of the communities that they're serving is really important.
That's awesome. So I hear there's a lot of resources out there that we can work with you to tailor to your specific community. So please reach out to any one of us to help in that process. Go ahead, Dr. Wright.
Sorry, I was just going to add another fabulous resource, our community pharmacists who have been increasingly active in blood pressure detection and control. And most of us visit the pharmacist more than we visit our pharmacists and pharmacies more than we visit our clinicians. So lovely other place that's right around the corner can help with blood pressure.
Wonderful. Awesome. These are great questions. So please, folks, please keep these questions coming in through the Q&A box, and we have time for just a couple of more questions. So someone asked, can anyone speak to the connection between high blood pressure during pregnancy and maternal mortality rates? And again, that's another one that's of great interest here in Region 6, where we have some very high maternal mortality rates, and we're working in our office to lower those as well. So I don't know if you can speak a little bit to that.
I can, and the percentages vary a little bit depending on how the period of measurement. But the bottom line is, hypertension is a major cause of maternal mortality. I have tended to focus in today's talk about morbidity, complications, but it is a major cause of mortality. And the thing that is just so heart-wrenching about that is that it's a largely preventable, controllable condition. And if women are dying of something that is that we're missing or not adequately recognizing and not in a timely way, that's just a tragedy, a preventable tragedy. So major cause. I'm glad someone brought that up.
Thank you. And if you'd like to get involved in some of our maternal health efforts, reach out to your local regional offices. I know several regions have initiatives in this area. So our next question is a really good one. What are some questions that we should ask, we as women should ask our providers about our blood pressure? What kind of questions should we be talking to our doctor about?
Well, the first two for me are, what was my blood pressure and what should I do about it? So I think asking a clinician, a nurse practitioner, a PA, a doctor is, what's the best blood pressure for me? Because I think there's been a lot of confusion about what numbers are the right numbers. The guidelines actually got into a big hoorah about whether it's 140 at the top or 130. The current recommendation by most major guidelines is less than 130 on the top and less than 80 on the bottom. There are exceptions to that. So the number varies with the person and their risk factors and should be decided upon by that person and his or her medical team. But each person should know, what numbers am I shooting for? So what was my reading and what's my goal?
And then I would add to that, other questions about your lifestyle factors, like are you a smoker? Make sure you tell your provider, or are, something in your diet impacting it, or your physical activity, or their medications that you're taking. So I think you should ask, all the things that can impact, your blood pressure. And I'm going to put a link to a fact sheet too in the chat for actually has questions, sample questions. So you can take that with you to your provider and ask these questions.
You know, Nell, you remind me another important thing for you to say when you meet a clinician for the first time is to let them know if you had high blood pressure during pregnancy. I thank you again for the opportunity to say this. High blood pressure during pregnancy of any of those types, or any flavor of hypertension during pregnancy, does increase that person's risk of heart disease and stroke in their lives. And so you want to clue your medical team that you might have that increased risk. So they should intensify their screening, looking at a blood pressure level on a regular basis, a cholesterol level on a regular basis. To your point, Nail, making sure that if you are a smoker, that you get the support you need to stop. And so managing all those risk factors can actually wipe out that risk. You don't have to have it, but it has to be known. And often once a woman has delivered, that obstetric history gets lost in the past. You may talk about it at an OBGYN visit, but not with a primary care cardiologist or others. So let them know that you had hypertension during pregnancy.
Some great advice. That is all the time that we have right now. And so I appreciate all the panelists today. I would really encourage you to engage with all of our panelists, representing just a few of our many HHS offices and initiatives when it comes to hypertension in women. And so we hope that today's presentations reinforce the importance of making heart health a priority for women across all stages of life. The resources that were mentioned throughout today's call will be included in a follow-up email to all the attendees. The recording of this webinar will also be available for viewing next week on the OWH's YouTube channel, and attendees will also receive the recording link once it's live. If you need more information or have follow-up questions, please don't hesitate to contact OWH at womenshealth@hhs.gov. And one more time, I'd like to encourage you to also reach out to your regional offices as well. Thank you all again for joining us during National Women's Blood Pressure Awareness Week, and have a wonderful day. Thank you so much. Take care.